Hello, my name is Shonda Street, and this is my presentation on hepatitis B for Nursing 7103. The patient's name is Myliv R. Damage. She's a 31-year-old unvaccinated female who works as a travel photographer. Her symptoms includes she reports 4.5 months of fatigue, loss of appetite, 20% weight loss, nausea, vomiting, and mild right upper belly pain. She also reported a low fever, joint pain, and muscle aches. Her exposure included the fact that she got a tattoo with an unsterilized needle in Hanoi, Vietnam. She has no history of IV drug use. Her disease progression, week 0, that was her exposure to Hep B via the unsterilized needle. Week 10, fatigue and appetite loss started. Week 14, she noticed some jaundice or yellowing and a high bilirubin of 3.4. And week 16, an enlarged liver, plus 2 centimeters. Diagnosis, acute hepatitis B. High liver enzymes. She had an ALT of 285 and an AST of 192. Positive hepatitis B surface antigen and anti-hepatitis B C IgM. This confirms recent infection. Detectable HBV DNA at 22,000 and likely genotype BC, and this is common in Southeast Asia. The cause is she's unvaccinated, and she had an exposure to contaminated tattoo tools. Some essential history data that we need to gather and key questions to ask. I would ask open-ended questions to uncover risk. So I would ask things like, have you ever received any tattoos, piercings, or other cosmetic procedures done outside of licensed clinics? Um, I would ask about any medical care like dental work or surgeries in countries where hepatitis B is common. For moms, I would ask, were you tested for Hep B during pregnancy because babies can catch it at birth? I would also ask about vaccination history. I would ask the patient to show me their vaccine record. Many people mix up what shots they've had. I would ask where they were born because some countries only receive or recently added HPV vaccinations, i.e., Vietnam, and they added those in 2003. For healthcare workers, I would ask when was their last antibody check, okay, and do they need a booster? I would ask about the symptom timeline. Did the yellow skin or dark urine start 23 months after exposure or before? I would look for chronic signs like bruising or leg swelling, like due to cirrhosis. And I would ask about emergencies. Like, have they had any vomiting of blood or confusions? Okay. The vomiting of blood can indicate varices, and the confusion could indicate hepatic encephalopathy. For my Liv's case, I would ask specifically about the tattoos. I would ask, was this a street stall or a licensed shop in Vietnam? I would ask if did she watch them open any open needles? Did she see gloves? And how soon after did she feel sick? I would also ask about other risk, any unprotected sex since your trip, and medical/dental visits abroad. Again, symptom check. Ask about her yellow eyes, extreme tiredness or pain after fatty meals. And I also ask about any new or easy bruising that she's experienced. Okay. Practical next steps for my Liv. I would plan more travel. Or I would ask her about, is she planning any more travel to high risk areas? And if she has had unprotected sex, does she need help telling partners to get tested? And also the psychosocial aspect, worrying about, the cost or what people might think. And here is subjective information from my lift. She said, Doctor, I got this tattoo in Hanoi 4.5 months ago, and now I feel terrible. The artist wiped the needle with alcohol, but I didn't see him open a new package. About a week ago, I was so tired I could barely work. My urine is dark like tea, and my friends say I've lost a lot of weight. I've noticed recently that my eyes and skin are a bit yellow. I've never had the hepatitis B vaccine. My mom was against vaccinations when I was a kid. I'm scared because my travel buddy got the same tattoo, but he feels fine. Could it be from the street food? I did have unprotected sex last month, but I can't remember the guy's name. Anyway, he said he was clean. Here are my Liv's risk factors. Her risk factors include the unsterilized tattoo, unprotected sex, the fact that she's unvaccinated, and the genotype is B/C. Probable genotype is B/C. My Liv's symptoms were easy to dismiss initially. Fatigue and nausea could be the flu. But the progression to jaundice and the enlargement of the liver, coupled with her unvaccinated status and tattoo exposure, paints a classic picture of acute hepatitis B. Her tattoo isn't just body art, it is our way of looking at it as a smoking gun. My Liv's case teaches us to listen when our patients say it's just the flu, especially when their history indicates high risk exposures. Her tattoo was a stealth exposure, as cultural experiences often override health precautions. So, my Liv's vital signs when she came into the clinic were she had a normal blood pressure, normal heart rate. This suggested there was no sepsis or hemodynamic instability despite acute hepatitis. It rules out like compensatory tachycardia and dehydration despite the 25-pound weight loss. She had no fever, which is typical for uncomplicated acute hepatitis B, unlike hepatitis A and E, where fever is common. Fever would raise concern for like a superimposed infections, um, of the gallbladder, maybe abscess. Alternate diagnosis could be Epstein's Barr virus, CMV hepatitis. Her her pulse ox, her SpO2, excludes any hepatopulmonary syndrome. So, and that's very rare in HBV. Okay. If she did have like a blood pressure drop, it would reflect like a catabolic state for prolonged nausea and malabsorption. So if she did have a drop, it could be because of the malabsorption. Um, Also, slower hepatic regeneration, medication toxicity. So monitoring, we want to just monitor her vital signs every 4 hours while she's inpatient and watch for hypotension and encephalopathy. So priority changes would be a greater than 20% drop in her blood pressure, and that's a big concern for the hepatorenal syndrome. A heart rate, increased heart rate, it may indicate like a GI bleed or pain, and a temperature that's greater than 38 degrees Celsius. You want to evaluate for secondary infections like SBP, which is spontaneous bacterial peritonitis. So this is her diagnostic results, her lab results. So my Liv's normal WBC, um, she had a normal WBC and it was 6.2. This helped us rule out any superimposed infections like sepsis or gallbladder issues, cholangitis. Her mild anemia was at 12.8. This reflects chronic inflammation from prolonged viral activity. We'd expect lower hemoglobin if this were acute, like an acute GI bleed. Her platelets were at 185, and that's reassuring. They had been 150. If they had been 150, we'd suspect portal hypertension. Her liver injury pattern, the ALT, which is 285, it dominates over the AST at 192. This is classic for viral hepatitis. In alcohol hepatitis, we see AST and ALT that's greater than 2. The direct bilirubin at 2.8 uh, confirms a hepatocellular injury rather than obstruction. Note the normal ALP. This isn't a disease of the gallbladder. Synthetic function. Her albumin was 3.8 and her INR was 1.2. They're borderline. While technically normal in acute liver injury, we prefer an albumin of greater than 4 and an INR of less than 1.1. These warrant Q48-hour monitoring and INR and INR rising over 1.5 signals the synthetic dysfunction needing ICU evaluation. HBV serology, the um, the the hepatitis B surface antigen, if it's positive, and the anti-HBC IgM is positive, that confirms acute hepatitis B virus. The pending HBV DNR PCR is critical, and it loads like greater than 20,000. That may indicate a higher risk of a chronic infection. In endemic regions like Vietnam, a genotype testing would typically follow, and she is in Vietnam. Clinical correlations. 3 surprises in these labs. The degree of the ALT evaluation suggests robust immune attack. This is good if it's transient, risky if it's prolonged. Normal platelets, despite the spider angiomas, may indicate early fibrosis without portal hypertension. Borderline INR, despite marked jaundice, hints at her liver function reserves. So, my Liv's exam reveals the classic triad of acute hepatitis. She does have some tenderness at the liver with spider angiomas. But the severity of her weight loss and those spiders suggests this infection may have been simmering long before she reported it. It becomes visible at the bilirubin that's greater than 2.5. Her dry oral mucosa hints at dehydration from nausea and vomiting, and this is common in acute hepatitis. The spider angiomas typically appear when estrogen elevation appears with estrogen elevation from chronic liver disease. Seeing them in acute hepatitis implies either the disease is progressing faster or she's had it for longer. So, what is hepatitis B? Hepatitis B is a highly contagious virus that attacks the liver, causing inflammation. This can lead to acute or chronic infection. Chronic hepatitis B increases the risk of cirrhosis, which is liver scarring, liver failure, and liver cancer. So, how is it spread? Hepatitis B is spread via contact with infected blood or body fluids. Even a tiny invisible amount can lead to infection. Common routes are unprotected sex, sharing needles, and mother to baby during childbirth. Key differences from hepatitis A. It is not spread through food or water, unlike hepatitis A, and it is more dangerous. It can become chronic, leading to a lifelong liver damage. Symptoms include, well, often in the beginning, there are no symptoms. You may have fatigue, nausea, loss of appetite, jaundice, which is yellowing of the skin and eyes, and in severe cases, cirrhosis, liver cancer, or liver failure. Why early action matters. There is no cure for chronic uh, the hepatitis B virus, but treatments can control the virus. Vaccination prevents infection. It is critical for high risk groups. So the takeaway is hepatitis B is a silent but serious threat to the liver. Prevention via vaccine and early detection are key to avoiding lifelong complications. So the timeline that I have here um, shows the hepatitis B virus predictable march through the liver. So after exposure, the virus stealthily replicates for about 6 to 12 weeks before the serological detection. Notice the critical divergence at 6 months. Most adults clear the hepatitis B virus, but some enter into it like a chronic phase. So, unlike most hepatotrophic viruses, so think hepatitis A and hepatitis C, hepatitis B is a DNA virus. This matters because DNA viruses can integrate into host genomes, creating long term reservoirs, which is a major hurdle for cure research. The hepatitis B surface antigen um, is our diagnostic workhorse. It is detectable in blood weeks before the symptoms occur. But here's the catch: this surface antigen comes in a mutant form that evades tests. It always pairs with IgM anti HB hepatitis B C in suspected acute cases. The core antigen um, is the virus's hidden identity. It is locked inside the hepatocytes, invisible in blood tests. We detect it indirectly via the anti hepatitis B C antibodies. IgM anti HBC equals acute infection. IgG equals chronic past exposure. DNA polymerase. This enzyme is hepatitis B's copy machine and a prime drug target. It lacks proofreading, causing mutations. This explains why monotherapy breeds resistance. Modern uh, drugs attack multiple polymerase sites. HBV stealthiness lies in its CCC DNA. This is a molecular sleeper agent invading immune detection. MyLiv's TAC2 exposure provided the perfect entry point. While most adults clear the hepatitis B virus, her malnutrition and dehydration diagnosis increase risk for a chronic infection. It mirrors Asia's genotype B/C ACC epidemic. Some teaching points include CCC DNA explains treatment challenges. Genotype does matter. B-C have a 40% higher cirrhosis risk than A and D. Vaccines are the vaccine era divide. MyLivs represents the unvaccinated group. Long before hepatitis B was identified, outbreaks were documented as icteris or jaundice in ancient texts. The 1885 Bremen outbreak, linked to smallpox vaccine contaminated with human lymph, was our first clue that hepatitis could be spread via blood. This serum hepatitis puzzled scientists until a chance discovery. Bloomberg's breakthrough while studying blood polymorphism in indigenous Australians. Bloomberg found an antigen that reacted with hemophilia patients' blood. This Australian antigen turned out to be hepatitis B surface protein. This was the foundation for modern diagnostics and vaccines. The first plasma derived vaccine in 1981 was groundbreaking, but carried HIV fears. The recombinant vaccine in 1986 eliminated this risk, paving the way for the World Health Organization's 1992 recommendation that all countries vaccinate infants. Vaccination prevents over 700,000 deaths per year globally. Vietnam's progress. In Myliv's exposure country, hepatitis B virus was endemic due to perinatal transmission. Since 2003, Vietnam's vaccination program has slashed chronic rates by 50%, but gaps remain, like Myliv's unvaccinated tattoo artist. This history is a reminder: vaccination isn't just personal, it is a public health duty. Hepatitis B global facts from the World Health Organization. 296 million people live with chronic hepatitis B worldwide. 1.5 million new infections happen yearly, and that is equal to a city the size of Philadelphia. It is most common in the Western Pacific area, that's at 6.2%, and Africa at 6.1%. And this is due to limited vaccines and healthcare access. In America and Europe, it is less than 1%, and this is thanks to a strong vaccine program. Babies are at high risk. 90% of exposed 90% of exposed infants infants that were exposed at birth develop chronic hepatitis B. This keeps the virus spreading in affected regions. So the one key takeaway is that vaccination saves lives, especially for newborns in high-risk areas. HBV is the leading cause of liver cancer worldwide, accounting for 45% of all HCC cases. This means that nearly half of all liver cancer diagnoses can be linked back to this one preventable infection. Annually, there are about 820,000 deaths caused by hepatitis B. To put this number in perspective, someone dies of hepatitis B every 38 seconds. The virus also costs around $20 billion every year in healthcare, with 80% of that affecting low and middle income countries. To put this in perspective, this is the equivalent of being able to build 400 modern hospitals in the developing world every year. This isn't just a health crisis, it is huge. It is a huge economic blow to the most fragile health systems in the world. Clinically, many adults in some Asian countries are chronically infected. These patients often do not know their status until they develop cirrhosis or liver cancer because hepatitis B is a silent epidemic. 80% of chronic carriers are completely asymptomatic until late-stage disease. The positive news is that the hepatitis B virus vaccination reduces chronic infection by 90%. This is incredibly great and is a very high efficiency, meaning hepatitis B is on track to be the next smallpox, completely eradicated through vaccination, if we are able to equitably distribute it globally. The issue isn't the virus itself. The tragedy is we have had the tools to eliminate it for decades, and yet implementation has lagged. So early versus late manifestations of hepatitis B. So early hepatitis B announces itself loudly. So you'll have like jaundice, sky high, ALT, but 90% of adults clear it. With chronic hepatitis B, it's a silent saboteur. Patients feel fine until cirrhosis develops. Um, Note that joint pain, rashes, and this is seen in about 20% of chronic cases, stem from immune complexes. So, some diagnostic criteria. So, the surface antigen is a cornerstone. So, positive, it is positive for both acute and chronic. The IgM slash IgG switches, that's what distinguishes the phases. So DNA levels guide treatment. So if it's over 20,000 in acute, suggests a higher risk for chronic infection. So when the surface antigen comes back positive, don't stop. You want to always check for co-infection. So you want to look at, is it hepatitis C, hepatitis D. You want to rule out any competing causes like alcohol. Just remember that the AST will be greater than the ALT. That suggests alcohol, while with hepatitis B, typically shows the ALT is greater than the AST. While we've established hepatitis B as a primary diagnosis for MyLives, let's briefly address why we excluded these less common but important alternatives. Primary biliary cholangitis, or PBC, was essentially ruled out by the negative AMA. That's the hallmark antibody that's present in 95% of all PBC cases. Now, for primary sclerosing cholangitis, or PSC, we've had two strong negative findings. First, the MRCP showed completely normal bile ducts, and second, she had no personal or family history of inflammatory bowel disease, which coexists in 70% of PSC cases. Drug-induced injury, or DILI, required brief consideration given her NSAID use, but the timelines didn't match. Her symptoms began months after last use, and there were no characteristic mixed cholestatic hepatic patterns on labs. Wilson's disease, the Wilson's disease screening was straightforward. Normal, no Kaiser-Fleischer rings on the slit lamp exam, and no family history of this autosomal recessive condition. The remaining conditions were easily excluded. Viral resistance requires a prior treatment history she didn't have, and Reye syndrome was impossible without aspirin use during the viral startup. This focused workup demonstrates how targeted testing, the AMA, the ceruloplasmin, and the single MRCP effectively and efficiently ruled out these alternative diagnoses while confirming the hepatitis B. Hepatitis B transmission and viral entry. So the NTCP receptor is liver specific and it makes hepatocytes the sole target for the hepatitis B virus. There are treatment potentials. There are drugs that are in trial right now that block the NTCP to prevent infection. Genetic resistance. Some individuals are resistant to hepatitis B due to the NTCP polymorphism. The key viral agents, you have your hepatitis B surface antigen. It is the detectable marker for current infection. You also have your hepatitis B-C antigen, which is your the core protein. It's the hidden core protein that triggers the anti-HBC antibodies. Then you have the HBE HBAG or surface or antigen, HBe antigen, and it indicates high viral replication and infectivity. Hepatitis B virology and hepatitis B replication cycle. The CCC DNA in the nucleus acts as the virus's blueprint, making viral mRNA. mRNA is translated into viral proteins. So think of your hepatitis B surface antigen, hepatitis B core antigen, polymerase, and hepatitis BE antigen. pgRNA gets packed into new virus cores. Reverse transcription converts pgRNA to rcDNA, that is the virus's genetic material. New virons assemble and exit to infect more cells. The key point of this is that cccDNA's persistence makes HB or hepatitis B hard to cure. Immune response. Hepatitis B is a battle between viral stealth and immune vigilance. When Myliv's virus entered her hepatocytes, her immune system launched a two-phase counterattack. There was an innate response. Within hours, her natural killer or her NK cells and the interferons tried to contain the virus. But the hepatitis B virus evades these with viral proteins that blunt interferon signaling. This explains her initial flu-like symptoms at month 2. Then there's the adaptive response. By month 4, her cytotoxic T cells are aggressively attacking the infected hepatocytes, causing the ALT to spike to what we see now. The yellow in her eyes, that's bilirubin from this collateral damage. Here's the catch. Hepatitis B virus exhausts T cells over time. Without a robust antibody production, which Myliv's lacks due to her no vaccination status, the virus may win this war, leading to a chronic infection. So in closing, for Myliv, we are now at the tipping point. Will her T cells prevail or will the hepatitis B virus exhaust them? Next week's surface antigen retest will tell. In acute hepatitis B virus, the T cells swarm the liver like elite forces. Their aggressive attack causes the ALT to spike to what we see in Myliv. That's the 285. But in chronic hepatitis B, the T cells become tired. They're like little tired soldiers. The PD-1 upregulation and T regulation suppression leave them ineffective. So tissue damage patterns. So under the microscope, acute hepatitis B shows lobular disarray with dying hepatocytes. So think of like a battlefield after that battle. So the battlefield aftermath. Chronic hepatitis B reveals ground glass cells, hepatocytes. Those are hepatocytes packed with like surface antigens, too overwhelmed to function. So the clinical correlation, Myliv's like spider angiomata hint at possible early fibrosis. Had we biopsy, we might see portal inflammation already. Clinical implications. cccDNA is the unyielding foe. The hepatitis B virus's cccDNA is like a sleeper agent hiding in hepatocyte nuclei. Current drugs cannot eliminate it. This is why, even after 10 years of therapy, stopping treatment risks reactivation. For Myliv, this means lifelong monitoring if she progresses to chronic infection. Antigen monitoring is the crystal ball. The HBe antigen tells us about the viral activity or load. Its loss or seroconversion is a key treatment milestone. The surface antigen levels predict outcomes. Myelin needs quantitative surface antigen testing at 6 months to guide therapy decisions. Hepatitis B surface antigen is considered the fatigue factor. MyLiv's high surface antigen load isn't just diagnostic, it is actively exhausting her immune system. These surface proteins act as decoys, diverting T cells away from infected hepatocytes. This explains her persistent fatigue despite normal hemoglobin. HBE antigen. This is the transmission amplifier. If MyLiv's HBE antigen is positive, she's highly contagious. Her tattoo artists and others could be at risk. But if she's HBE antigen with high DNA, we're still dealing with a pre-core mutant that's common in Asia that's still infectious, but it is harder to detect. HBX, we consider that the silent oncogene. If MyLiv's probable genotype is BC, the HBX protein is already sabotaging her hepatocytes by disabling the tumor suppressor gene, which is P53. It's promoting angiogenesis, that's the HCC fuel, so that's the liver cancer fuel. This mandates ultrasound surveillance even if she clears that surface antigen. Polymerase is the treatment bullseye. When MyLiv's hepatitis B virus DNA results return, we'll choose the antivirals based on the polymerase mutation profile. And here's just a chart showing her viral protein clinical correlations. So hepatitis B doesn't just affect the liver, it is a systemic saboteur. While MyLiv currently shows acute hepatitis, there are devastating complications that we are trying to prevent. The 0.5 statistic is a cold comfort when hepatitis B triggers massive necrosis. We know then that mortality rockets to about 80% without transplant. So you want to watch for mental status changes, and that includes flat arm flapping, confusion, and hepatic encephalopathy. You want to watch for an INR that's greater than 1.5, and you want to look for hypoglycemia. With chronic liver disease, we know cirrhosis isn't just scarring, it's vascular chaos. Portal hypertension causes varices that increase bleeding risks to about 30%. Enlarged liver and the hepatorenal syndrome. Hepatocellular carcinoma. HPV causes HCC differently than hepatitis C. There's direct oncogenesis. The viral DNA integrates into host genome. No, there's no cirrhosis that's needed, especially genotype C, and this is the one that's common in Vietnam. Surveillance is ultrasound every 6 months, alpha fetoprotein in high risk, plus alpha fetoprotein in high risk patients. So MyLiv's risk, her TAC2 exposure likely introduced the genotype BC, both HCC drivers. Extra hepatic attacks. So when HPV forms immune complexes, expect vasculitis, renal injury, skin lesions, ascites, and ascites happens when portal pressure exceeds 10 mm of mercury. We get ascites. MyLiv's current normal albumin is 3.8. It protects her, but if it drops below 3, fluid will flood her peritoneal cavity. Diagnostic paracentesis should show a SAG score of greater than 1.1 and low protein. Also, anasarca. This isn't just swelling, it's total body fluid overload. And this is from a low albumin, low oncotic pressure, and secondary hyperaldosteronism, which leads to renal salt retention. In hepatitis B, this signals end-stage liver disease. My Liv's risk, her 25-pound weight loss, mask edema. Always check sacral and presacral areas. You want to also look for any peripheral edema, and you want to. This is demonstrated by pushing on the foot or the leg and looking for pitting edema. Unlike cardiac edema, hepatic edema starts bilaterally, but is more prominent in the sacral region, so supine patients. It worsens with low albumin. It doesn't improve with diuretics alone, so you do need albumin infusions. Exposure to acute phase, that's week 6 through 12. MyLiv's TAC2 exposure introduced the hepatitis B virus into her liver via the NTCP receptors. Those are considered the virus's front door. By week 6, the surface antigen became detectable, though she dismissed early fatigue as travel exhaustion. Immune response is months 2 through 4. Her current ALT of 285 reflects a raging T-cell attack. The jaundice signals hepatocyte necrosis. Those spider angiomas suggest the battle has been brewing longer than reported. In hepatitis B patients, clinical red flags will be an ALT greater than 500 plus bilirubin greater than 2.5. This equals a risk of fulfillment hepatitis. Overcome crossroads, that's at month 6. By month 6, we'll see either clearance of the anti-HB hepatitis B cells. That's going to give us like a 90% of like a robust immune response, or you're going to start seeing the chronic infection taking place, and that's where you still have those surface antigens, the hepatitis surface antigens, and that's likely due to the fact that she has a type C genotype and she has delayed care. So action items will be quantitative surface antigen at 6 months. It predicts if the infection is going to become chronic. You want to monitor her and then start her on medication. Chronic complications. If chronic, MyLiv faces cirrhosis. She does have genotype 2. It progresses 2 times faster than B. Liver cancer, and your risk with 35% is 35% with cirrhosis, and liver failure. MELD scores need monitoring frequently. So supportive care. So MyLiv has a 90% chance of full recovery within 6 months. The 10% chronic risk is higher if her baseline ALT was greater than 1,000 or genotype CD, considering testing if she still has those surface antigens at 3 months. You want to make sure she's hydrated. You want to monitor again for fulfillment hepatitis, lab tracking weekly ALT and surface antigen until ALT declines, and check hepatitis B DNA if hepatitis B surface antigen is positive in 3 months. And again, here's a flow chart of recovery. You have your surface antigen. Is it chronic after 6 months? If yes, then you're going to start them on medication. You're going to check to see if the DNA is undetectable, and then they're going to have lifetime monitoring. If it's no, then you just want to monitor those anti-hepatitis B cells. So again, if it's chronic, you're gonna go through therapy. The first line therapy is medication, tenofovir, and that's 25 milligrams a day. The advantage is you have renal and bone safety versus older medications. And again, you want to monitor their labs every 6 months. Fiber scan, which checks the stiffness of the liver, annual ultrasound, and alpha fetoprotein or HCC screenings. So prevention, MyLive does have a 90% chance of full recovery within 6 months. The 10% chronic risk is higher if her baseline ALT was greater than 1,000 or if she's genotype C/D. Consider testing if she still has those surface antigens at 3 months. We want to make sure that her sexual partners and her family members are vaccinated, and make sure she informs any sexual partners that she's had from the time she was diagnosed to present. Tell them of her status and make sure they are tested. You want to have PrEP for future exposures, and the HB1G plus vaccine within 24 hours. That is all. Thank you very much.